So is everyone seeing the slides changing, or are there only a few people seeing the slides changing?
No, it stayed the same slide the whole time.
Yeah.
Okay, I'll try sharing again then.
Okay. Yeah, it changed there.
Yep.
The Word document sounds very distracting. Okay, please let us know if it doesn't work out again. So as I was saying, between December 2021 and March 2022, the team led by Sheri gathered the experiences and stories of Indigenous patients who had received care here at St. Paul's Hospital. So the report being presented on today describes a pilot of how using the patient journey mappings has become one of our tools, one of our core and routine engagement pieces to help us move forward with implementing the Indigenous Wellness and Reconciliation Action Plan. This data that is collected from the patient journey mapping experience does combine with other data that we have collected as well, all of it again feeding into that action plan. The report itself puts forward a set of implementation priorities and guidance to support teams and individual staff and medical staff members and how they can work to implement IRAP. They are not meant to replace the goals or priorities outlined there, but they are more of maybe indicators or can provide specific actions that all are based on the patient's voices. It involves a collaborative production of a retroactive visual map that you see. So you see some examples on your screen today. Our first ever one did take place here in November in our All Nation Sacred Space at St. Paul's. It was facilitated with our teams and with the support of a graphic facilitator. Next slide. So why are we doing these? Mapping these journeys allows us to get more insight from patients. It allows the participants to represent their current realities of their experiences and how they interacted in the hospital health system. And it points to improvements. It also can point to some strengths and opportunities, all, like I said, from their point of view. We use this to collect and use their data as a sign of, a measure of how we're doing. Continuous improvement is really important for our team, especially as this is, particularly new ground for the organization. The IRAP is only in its first year. So it's a good opportunity for everybody to move forward. What do they tell us? They tell us how we are doing as an organization. They allow us to measure that progress. They guide us and show us where we need to go. It helps us target our interventions better with more precision, and it's all driven by data. And the maps and findings are being shared across Providence Health to inspire action and encourage support from across changes. So far we have done grand rounds to almost every medical group across the organization. And there are hopes to start moving into some of the other areas, including corporate and nursing and some of the other areas that we have not yet had a chance to do those more specific targeted rounds for. The report represents 2 rounds, like I said, from November 2021 to March 2022. We have conducted 2 more rounds since then, but those ones are still in the process of data collection and analyzing. So, stay tuned for report part 2. It was facilitated by the graphic facilitator, as I said. As far as our participant selection, we used a bit of a convenience method, a bit of a snowball method, where we consulted those patients that are attached to our program, approached them and asked them if they wanted to be participants in this experience. And doing some of that actually helped them also talk to their friends and family, and we started to also notice other people becoming aware of this experience. And unlike other patient journey maps, which are more technical in nature and take you from pre-admission all the way through to post-admission, ours was really driven by one open-ended question, and that is, what was your experience at St. Paul's? And through that process, it allowed the patients to lead us directly where they wanted us to go with them on the journey. Once we had all that information, we compiled and analyzed the transcripts and the maps and identified some key themes and implementation priorities, which we'll talk to you a bit more about. Who participated in these first 2 rounds? We're looking at 42 Indigenous patients who all received care at St. Paul's Hospital within the last 24 months. There were predominantly females who were taking part, and the age span was, from about early 30s into the late 60s. By and large, most of the participants were from the sort of lower mainland Greater Vancouver area, but we do recognize we serve a lot of patients from across BC and also into Yukon and some other places. So, we're mindful of making sure that the information we collected also reflects, the various traditions of places. The patients, reported basically visiting various units. I'm hard pressed to think of a unit that hasn't come up through the patient journey mapping experience. I mean, every single unit has come up in one form or another. So our key themes at a glance, we've identified 5 themes coming out of this. 2 of them are particularly focused from the patient experience side, and 3 of them are more external. So the first one being cultural safety, Indigenous cultural safety in particular. Then transitions and stages of care is another theme that's really important when it comes to working with Indigenous patients. Indigenous cultural services, physical built spaces and built environments, and the health system transformation piece overall. And now I'll turn it over to Sheri, and she will take you through these mapping experiences.
Yeah, so the first one that I'll talk about is the patient experience and cultural safety. The first map that I'll talk to you about was a map that was created with a male in his mid-60s. He's sadly actually just passed away about 5 months ago now. He visited cardiac, the emergency department, surgical, and the ICU, and had a mostly positive experience. This gentleman stated, "I was born at St. Paul's Hospital in 1955, so the hospital has a special history to me. However, I have come to learn that a hospital is not necessarily a place to rest. I would like to have a deeper connection with care providers and talk more about culture and ceremony." The quote that this gentleman gave us that stood out most for us was, "It costs $0 to be nice to someone." So it costs $0 to be nice to someone. To have somebody actually state that, for a few people in these sessions, there were overall positive experiences at St. Paul's Hospital. And we were able to hear many examples of desired attributes of a culturally safe experience. Those attributes being respect, someone feeling respected when they come into the hospital, reciprocity, being able to have a back and forth conversation with someone, relationality, feeling like that person actually cares about you, cares about your care, the feeling of safety, feeling safe in the environment, feeling like you're in a good space where people actually do want to care for you, feeling empowered, feeling like you're actually a partner in the healthcare journey that you're on, like you can actually make decisions, and equity, feeling like you're being treated equally as any other patient would be treated in any visit to the hospital. However, in many cases, we heard mostly negative experiences at St. Paul's Hospital, with small threads of cultural safety woven throughout. Many of the positive culturally safe experiences actually were related to interactions and relationships that were built with the Indigenous Wellness Liaison team as well. The next journey map that I'll talk to you about, this was a 35-year-old woman who received maternity care here at St. Paul's Hospital. She had a relatively uncomplicated birth, and she was really feeling proud of herself. This happened in the midst of COVID. So a lot of challenges in the hospital at that stage of the game. Along with that, though, she actually experienced some trauma and needed to rest and heal in the hospital for a bit of time. Due to the isolation that occurred because of the pandemic-related restrictions, she also felt that she needed additional social and emotional support to combat a sense of loneliness, some exhaustion, and some depression. Typically, Indigenous women, when they're having babies, really involve their families. And because of what was going on with the COVID restrictions, she wasn't able to do that. So she continued to feel more and more depressed during her stay. When she actually reached out about her sense of loneliness and exhaustion and that depression that she was feeling, when she was seeking reassurance about the health of her baby, she actually felt ignored and stereotyped, and then felt disempowered in her attempts to actually breastfeed. Instead of being offered the postpartum and the emotional support that she needed, she was sent home. And once she was sent home, she was reported to child services. My buzzer rang, and there was a social worker and the police. I think that someone from the hospital called the Vancouver Aboriginal Child and Family Services and the police because they thought I wouldn't be able to take care of my baby. This leads us into the next topic, which is Indigenous specific racism, discriminatory treatment, poor quality, and access to care. They thought I wouldn't be able to take care of the baby, even after she expressed her concerns. Indigenous specific racism and discrimination are an enduring reality in healthcare. We hear about it almost daily here, especially throughout our department. Many instances of stereotyping and racism, such as being thought of as less worthy of care, being alcohol users, that being the first question that's asked to folks, being drug seekers, or being inadequate parents comes up over and over again for folks. As a result of this stereotyping and racism, a number of patients experienced discrimination at the point of care, felt that they were treated differently, felt that they were denied services, or felt that they were being made to wait as well. These fears related to being stereotyped or treated differently have really negatively influenced their care and or caused a lot of patients to actually not seek care at all. We've worked with and spoken with quite a few patients from the downtown east side who have actually refused to come into St. Paul's Hospital for any care at all. Compounding oppression is another area that's come up multiple times. I'll talk a little bit more about this patient journey map a little later on in the presentation. This patient in particular, though, coined the term the 3 strikes. Basically, she coined that term for herself as a substance user, someone who lives in the downtown east side, and is Indigenous. So indigeneity combined with socioeconomic status, with their physical appearance, with geography, with any health behaviors, tended to influence their healthcare experience in increasingly negative and mutually reinforcing ways. A lot of the patients expressed serious concerns around the St. Paul's Hospital security team, in witnessing and or experiencing anti-Indigenous racism, in being bullied or seeing bullying, seeing a use of excessive or unnecessary force, and really feeling a lack of compassion in the situation that they were in as well. There were a number of priorities for change that came up throughout this. Again, as Fancy had stated, these priorities for change actually came up in discussion with the patients. So the suggestions were for St. Paul's Hospital units to identify more ways to increase access to emotional, mental, and spiritual care, to prioritize Indigenous cultural safety interventions with security services, to audit patient charts. Just as an example for one of the patient charts that's been seen by the team, there was a gentleman who was in the hospital in ICU and was recovering from a procedure that he had done. When he was recovering, he was actually in the process of reconnecting with his own culture. He hadn't been aligned with his culture, hadn't been grown up with his culture. And in his learning about his culture, was able to learn some of the songs that his nation actually sings for healing purposes. So he was actually singing these songs while he was in bed in recovery. One of the care providers actually noted in his chart that he was speaking in tongues and was recommending potential services for mental health needs, not actually understanding what was going on with this gentleman, and that he was actually doing something that was really to support himself. Really dangerous area, having these things that could potentially be misdiagnosed by not asking questions. Also, recommendations around human resources collaborating with Indigenous wellness to actually create a culturally safe approach to equity, diversity, and inclusion. And developing policies that can address compounding oppression as well. There are a number of provider strategies that have come up here. I'll go over a couple of them. We can send this out to you after the fact as well. But things that were mentioned that people wanted to have happen: connect the patient with an Indigenous wellness liaison wherever possible. Adjust the care approach to allow for more time to ensure that there's actual decision-making together with the patient's needs. Being sensitive in how questions about substance use are framed, recognizing that past negative experiences within the healthcare system really impact how people feel when they come into the hospital. We have years and years of Indian hospitals that are in our history that we're still trying to overcome. Providing documentation to patients' needs for other services and explaining those documentation pieces. Providing options for transportation, addressing different needs that the patient may actually have come up that are special to them as well. The next area that I'll talk about is the patient experience, transitions and stages of care. Transitions of care came up over and over again for us, especially in the areas of travel to and from the hospital, the admissions piece, and discharge. This patient in particular identifies as female, and she's actually from the downtown east side and works really closely with a number of members who seek services in the downtown east side. When we take a look at this patient who co-created this map really talked about the need for folks to have access to Indigenous supports right away. In order to have people who don't trust the system, don't trust the healthcare system, feel safe when they're coming into a facility, make sure that they are connected with an Indigenous wellness liaison. There should be a knowledge keeper for all of the community resources available to a patient. So many people are discharged with no supports and nowhere to go. What we found is that there are challenges around accessing accommodations in Vancouver when traveling for care, and there's a lack of clarity around funding for travel. So connecting folks with a social worker or the Indigenous Wellness Liaison can help in that area. Travel services should address social, medical, and cultural needs as well, knowing that people have these different needs that really help them to feel safe. And many patients were actually discharged too early and or without adequate explanations and or supports, clothing and housing. We've heard from numerous patients that they were actually released wearing their hospital gowns, not actually having shoes as well. This next patient was a female patient in her mid-60s. She was visiting the emergency department, cardiac, surgical, and the ICU. And it really talks about some key issues in this upcoming section. This woman stated, people need cultural education. Most Indigenous women are modest. It's important for staff to remember to be mindful of patients' dignity and privacy. During her time at St. Paul's Hospital, she found a number of interactions disrespectful. She felt that any time I needed to ask for anything, even small things like a snack or a blanket, I was made to feel like it was a big deal and that I shouldn't bother the nurses. In the 65 days that this woman was at St. Paul's Hospital recovering, she was only offered help to have shower twice and was only able to wash her hair once. 65 days without feeling clean when you're trying to actually heal from a major incident. So, caring environments. That weekend at the hospital was the most humiliating experience of my life. In many cases, providers didn't meet basic comfort and care needs of patients, such as personal hygiene, having enough blankets, food, water, people coming in and not being there on time for lunch, but having not eaten for hours before actually arriving at the hospital. Many noted difficulties in having the confidence to actually ask for these basic needs as well, because they didn't feel like they were deserving of them. Many patients, especially those who indicate they use substances, emphasize those serious concerns with security, with experiencing anti-Indigenous racism, and with the use of excessive or unnecessary force. This next patient journey map that I'm going to talk about is a patient that identified as a female from a First Nation in BC. She's visited St. Paul's Hospital a number of times over the past 20 years. This patient was regularly attending cardiac appointments and has had 2 of her children here at St. Paul's Hospital. For this patient, her experiences, for the most part, have been negative. Her maternity experience have been difficult in terms of cultural safety and relationality. She stated, when I had my last baby, they did not bathe the baby right away, and I didn't know why at the time. It was not explained why. They said the next nurse will. Better communication would be good. I didn't know that they weren't washing my baby because it was better for the baby. I thought they just didn't want to do it. So with that, really understanding communications and coordinations of care. Several patients reported that patient-provider communication was good or excellent, but many patients identified the need to strengthen the transparency and the clarity around the information that's shared, really understanding what's going in layman's terms, and knowing that it's delivered in a culturally safe way. Looking at this in terms of prognosis, prescribed medications, understanding why they're getting what they're getting and why they're not getting maybe what they thought they were going to get, pre and post operative procedures and lab results. What we're finding is that a lot of patients who are leaving the hospital and don't understand the post-operative procedures or what they should actually do when they leave the hospital end up back in care again because they haven't cared for what they need to properly. Many patients noted aspects of care that overall related to the need for better coordination and shift changes. We heard a number of stories from patients about being left on commodes. One woman who actually was left sitting on a commode for about 4 hours during a shift change when she really felt uncomfortable and needed to go back to her bed, but couldn't make it there on her own. Priorities for change. Indigenous wellness liaisons to be able to partner with different units to create culturally safe and patient-facing discharge communications, walking them through, ensuring that they understand, designing more education opportunities for staff to learn about Indigenous lifeways so that we aren't dealing with situations like the chart audit where someone thought this person was speaking in tongues, advocating within the healthcare system for resource allocation, knowing that there are quality improvements that can improve the situations that we're dealing with right now. Identifying strategies for better communications, reviewing practices, identifying improvements for care coordination, ensuring that if somebody has asked for something and somebody doesn't have time to do it, that the next person that's taking over for them does know that they need that. Improving shift change protocols, increasing visibility for patients, introducing yourself to the patients so they know who you are, and building in more regular bathing opportunities for patients as well. Indigenous cultural services is the next section I'll talk about here. This patient it was Métis, identified as Métis, and this patient was the one who came up with the term, the 3 strikes. When she was actually working with us in here, she was the patient who stated she had never had a more humiliating experience in her life. She's been to St. Paul's Hospital several times for care over the last 15 years. She's been to units such as the emergency department, the ICU, and a number of floors upstairs as well. Overall, she spent many months here at St. Paul's Hospital. She struggles with substance use and she's dealt with many serious illnesses and related complications. She felt she was stereotyped, not listened to, denied service, and forced out of the hospital with what ultimately became a very serious undiagnosed blood infection. In general, this patient has stated that she has experienced many negative and culturally unsafe experiences, including a lack of respect and abusive treatment by nurses and security. She had stated that weekend in the hospital was the most humiliating experience in my life. She had a positive, trusting, and relational experience with her infectious diseases physician who was able to help her and ultimately resolve some of her longstanding health issues. However, for her, the interactions with an Indigenous wellness liaison were most impactful. She was a patient who actually experienced, had a colostomy bag and it wasn't changed. She ended up having an overflowing bag and she requested it to be changed and to have a bedding change. And she had to sit in her own feces in a bed for over 7 hours while she was waiting for somebody to respond to her. Her reactions and her interactions with the Indigenous wellness liaison, she had stated, I don't know what I would have done if I wouldn't have run into the Indigenous wellness liaison that day. It means a lot. It was a big help spiritually. I felt lost. The Indigenous wellness liaisons have helped to give me hope again, and I don't feel so alone. She was feeling quite suicidal at this stage of the game. And it was important that someone was able to come in and show that they actually really cared. So the Indigenous wellness liaisons have been mentioned and in pretty much every session that we've run. They had a very positive impact on patients and were mentioned in every single mapping session. The IWLs have been able to provide respectful, identity-affirming care, emotional, spiritual, and social supports, and linkages to community resources as well. Patients have reported that the IWLs have acted as patient advocates, being able to connect with other health providers and helping to bridge communication challenges when they don't understand things and actually don't feel confident enough to ask questions about the care they're receiving. Some patients noted that they would have benefited from longer and more frequent visits from the Indigenous Wellness Liaisons, and several patients actually noted that they didn't even know that the Indigenous services were available for them. Patients also noted that they would like to have access to elders, to cultural services, and traditional medicines. I felt so alone and isolated. Someone cultural could give me additional support. A number of patients expressed that they wanted to have access to these different services. Almost all of the patients actually mentioned this. Patients mentioned a variety of cultural services and ceremonies that they would actually like to see in order to feel safer as well, offered throughout St. Paul's Hospital. Having talking circles available, drumming and traditional songs, options for birthing, smudging and or cedar brushing. Another area that's come up that we're working really closely with a group of dietitians on right now is Indigenous cultural safe food as well. Food is medicine for most nations across Canada. Cultural foods are health affirming and healing for Indigenous patients. And specific foods can actually be a trigger and a source of trauma, especially for residential school survivors. Many patients felt that it would be important to integrate Indigenous foods into the hospital setting as they are healing and they're affirming. And they provided a number of different suggestions around the foods to be provided as well. Many patients mentioned that the patient food at St. Paul's Hospital is inadequate in a number of different levels as well. So priorities for change on this, units to work together again to better integrate and build relationships, enhance awareness of the Indigenous Wellness Liaisons and the care services that are available, involving Indigenous Wellness Liaisons at crucial points in the journey as well, travel, admission, transitions, and care. Food services, working with the St. Paul's Hospital dietitians to integrate traditional foods into the menus, expanding the IWL program. Currently, we only have 4 Indigenous Wellness Liaisons. We're hoping to have 23 by the time that we move into the new St. Paul's Hospital. We're hoping to have at least 10 by the time we reach the end of this year. We are also working with the emergency department to station an Indigenous Wellness Liaison right at the front entrance when people are coming into the department as well. The next area I'll talk about is the physical spaces and the built environment. This patient is a map that represents the story of a female in her mid-60s who visited cardiac, the emergency department, surgical, and the ICU. She talked a lot about physical spaces. The sacred space felt like home. There was a nice feeling smelling the medicines, sage, sweetgrass, seeing the colors. The room had a nice feeling. When they wheeled me back to my room, I was given a red blanket before I was released. I felt very special and very happy. It was the first blanket I've ever received from anyone. So culture, sacred spaces, and medicine gardens. This is our land. We need to be included. It's really important for people to have a place to perform ceremony and a safe place for Indigenous peoples to go. Patients reported that they were really appreciative of the All Nations sacred space, although they stated that it was really challenging to access at times. They've also noted, most of the patients noted that it was a cold, clinical, and possibly triggering environment at St. Paul's Hospital. Seeing images of nuns on the walls, seeing, the white walls or the scents that were in the hospital as well. Most of the patients mentioned the current All Nations sacred space in St. Paul's and were very appreciative that it was available to them, but many reported that access to a medicine garden would actually provide multiple benefits to patients, visitors, and staff as well. Number of priorities for change. We are working with the facilities team to find a way to relocate the All Nations sacred space so that it's closer for patient care and easier for people to see that they can actually access it. We're also looking for the option for a small medicine garden here at St. Paul's Hospital. and teams and facilities to continue to find ways to assist patients in feeling culturally safe and identifying affirming spaces for Indigenous patients through artwork, through design spaces. The last area, Fancy's going to talk about health system transformation. I'll introduce you to the patient journey map here and then pass it over to her. So this patient was unique, or this map was unique in that it involved 4 patients all at once. One quote really stood out for us. Peer support and Indigenous liaisons have such a positive impact and help with guidance on healthcare processes. Advocacy matters. There is a need to support Indigenous people. People need to be treated with dignity in any context. We are the voices for those who cannot be here. Another piece that this group talked about in particular, when entering the hospital, our guard is up immediately, and we remember bad experiences that we've had in the past. Any person with lived experience who have lived on the street have been mistreated here. People avoid coming in because of the negative treatment. People need to be treated with dignity in any context. You need to make sure we are hearing from the downtown east side. It's so important. There's so much suffering. Almost all of the patients talked about, all of these patients talked about security, and also stated when asked, I didn't want to say I was Indigenous.
And that last statement really actually resonates in terms of what we're going to talk about next, and that's around the Indigenous self-identification piece. For those of you who are joining us from St. Paul's, you'll be aware that we have had the Indigenous self-identification piece as an active part of Cerner since it came online for us in 2019. But we've also been asking the questions for many years, quite a few years actually, prior to Cerner. For the VCH folks, I know this is a fairly new process for you, starting in November, I believe, or December when you went live. And you know, there's a team over there that's doing some great work in terms of trying to figure out how to get the messaging out across the organization. But yeah, it really comes down to that dignity that needs to be attached to everybody who comes into this space. And for Indigenous people, that dignity has been denied for so many years. And that's why they haven't wanted to identify as Indigenous. We are working with the staff at the emergency department as part of an emergency safety project that's ongoing right now around improving the Indigenous self-identification process. We're rolling out new materials, updated materials, I should say, not new materials, but updated materials to help patients understand what their rights are, what their data is used for, why they can actually benefit from identifying. But for every staff, and we're talking beyond just the registration clerks at this point, for every staff person who comes into contact, it's always just a good idea to know whether or not somebody identifies. If you find out in the system that they have not identified, but you find out through your contact, you can ask them if they want to identify, and you'd be able to go into Cerner and make that change for them. And what that actually can help do is you can actually then also put in a consult to put these people in touch with the Indigenous Wellness Liaison team, who would be able to come and, you know, and visit with them, work with them, provide some cultural services if they require them. Staff training and education, that's another part of my portfolio. The Indigenous patients who worked with us told us very specifically that they had very, specific targeted areas they wanted staff to do more learning on, and that was trauma and violence informed care, culturally safe care and anti-racism, and harm reduction and substance use. I do have an Indigenous cultural safety lead who is able to work with teams and departments. We can tailor it as needed. We are doing actually a current project with the emergency department around this in particular, but I'm also working now with social work is doing some work in this area as well. We're doing a renal chart audit as part of the research challenge for 2022. So yeah, like a lot of departments are starting to figure out that what their educational training needs are around cultural safety and humility in particular, and approach our team to work with us. So in developing these, based off of the information provided to us from the patient journey mapping, we have identified various forms of learning and training that are suggested, including not just the trauma and violence informed, but violence prevention, addressing the anti-Indigenous racism, deepening the understanding of the healing and reconciliation, the vitality and the traditions of Indigenous people. When somebody feels fully confident and at their best, it really helps their healing processes along. Mental health and addictions, especially for ER staff and mental health and addictions professionals, and training on community resources that are available, because as I said, as Sheri has alluded to, patient travel is actually a frequent part of the experience for a lot of Indigenous people. And it just helps to know a little bit what that experience is like so that you can help it along as practitioners. And also very significantly increased training was specifically noted for security personnel and for nurses. Our priorities for change when it comes to health system transformation overall, we're looking at really developing strategies around training and change management and evaluation that ensures that every patient is being asked about their identity. They have opportunities to self-identify upon admission in a culturally safe way, and helping staff in understanding how to do that and how to work with patients and ask in a nice way. Aligning the patient journey mapping education and training findings with our evolving plans. There's nothing that I haven't heard here out of these presentations or these maps that isn't integrated in some way into our training planning. Working with departments and units to create their own specific planning, such as with the emergency department, really looking at how we can address stigmas attached to the downtown East Side residents. And also finding out how we can connect, leaders and staff here at Providence Health with more opportunities to learn about and do more community outreach for the downtown East Side. So with that, thank you very much for your time, and we're happy to take any questions.
Thanks, Sheri and Fancy. Fantastic work and talk this morning. We'll open the floor up to any questions. You can unmute yourself or drop a question in the chat.
This is Miles here. More of just a comment. First, I wanted to say thanks for a thought-provoking talk and for all the work that you're doing. I'm one of the cardiology fellows and a member of the Okanagan Indian Band, and I just wanted to mention that this patient journey mapping is something that is also being looked at and hopefully being integrated into research through the Canadian Heart Function Alliance. Part of the alliance is the IPERC, which I'm a part of, which is the Indigenous Peoples Engagement Research Council, and one of the priorities will be to use patient journey mapping through research as well. So I think this is a great example of the utility of that. So thanks a lot again.
It's awesome to hear. Thank you for sharing that, Miles.
Yeah, I'm not sure if you have seen Miles speak, but he delivered grand rounds here, but I think also across Canada, and we can share his talk with you. It's a really fantastic grand rounds and talk.
That would be great to see.
Any further questions or comments for Sheri or Fancy?
It's Chris and I'm in a car, so I apologize for the background noise. This is moving stuff, but I got the feeling that there was extensive negative. Is that the case? Is it extensively negative, or is it a mix?
So in working with the patients, there were a number of patients who did identify that they had some positive experiences as well. But yes, there's a reason that we're here. There are a number of patients that are experiencing some quite negative stuff when they're coming into the hospitals. Many have noted, though, that they've been able to make connections with specific doctors, specific nurses, where they've actually been able to start developing relationships, especially if they're here a little bit longer. I think in a lot of cases, what we're finding is it's the initial treatment when they're first coming in. And without being able to build that relationality and without feeling like they're being gotten to be known, the initial assumptions are what they're feeling right from the get-go. So.
Yeah, you have to remember also, a lot of people who are coming in who are Indigenous have experienced those really negative experiences in the past, be they small microaggressions all the way up to direct, experiences of racism from providers in these spaces. So they're already coming in with a very heightened awareness, alertness of, what's going to happen with each and every visit. There's always a higher level of almost anxiety or fear coming in for a lot of patients. This is not every patient's experience. If you ever see me in a doctor's office, I am very confident. But, I've reached a certain point in privilege in my life that I can say and do certain things, and I know the system and how to work it. So not everybody does. And it's just, this is why we want to work very closely. We're here, to talk with you individually or as units or teams. We're here to plan with you, workshop with you, work with you around how you can handle these things. Because one of the things about my job also is whenever somebody files an official complaint with the Patient Care Quality Office and they identify as Indigenous, I am automatically alerted to that so that I can become a co-investigator and so that I can offer, advocacy, support, and cultural services for that person going through the experience. So, I get to see mostly the negative, but I also get to see when those situations are resolved for the positive and where everybody walks away having learned something about how to do things better.
Thanks very much. Can I make one more comment, which
Sure, go
is
for it.
that feedback in the moment is highly effective, and all people tend to discount any report or feedback that comes very late. People go, "Oh, that was then. Oh, we don't do that. Oh, that wasn't my unit. Oh."
Yeah.
And anything we can do to accelerate the timelines and or try to solicit immediate feedback so that people can become aware at the time, I think would be helpful.
It would. You're absolutely right. I would just sort of say when it comes to certainly older Indigenous folks, if they've gone through a residential school experience, they've been basically raised by those schools to believe themselves to be not important enough to be heard or to express their concerns or their frustrations. My own parents, my own grandparents, I've witnessed going into the doctor's office saying things, "No, things are fine." And then I've got to speak up and say, "No, they are not. You're here for a reason," right? Because they've been basically taught by the system, by a colonial system that has been around them their whole lives, that speaking up is going to yield some form of punishment. And that's actually a big reason why we don't see as many complaints either, is because people don't want to be labeled as a troublemaker. So we have a long way to go in terms of building a system that is feeling safe, but I am confident in saying that the first steps are being made.
Perfect. One final comment, which was that campaign of "Ask Me If I've Washed My Hands," or "It's okay to ask me if I've washed my hands," or whatever. I forget exactly what it was, but it was very effective in attempts at empowerment or overcoming that. So thank you.
Thank you.
I have a question. Can you explain the Indigenous Wellness Liaisons a bit more? You have 4, and there might be 10 and 23, and if you know if those services or people are available at VGH and UBC?
Yeah, so Vancouver Coastal has what's called Indigenous Patient Navigators. They do some similar work that the Indigenous Wellness Liaisons here do at St. Paul or at Providence Health. So yes, both organizations have a similar function, although not perfectly aligned in terms of everything that they do. They can offer cultural supports in terms of taking people for ceremony, smudging, blanketing. We do allow smudging at all of our facilities. So there's a procedure online in our shop that tells you how you can go about making sure that the smoke detectors are turned off and things like that. They provide support and advocacy for patients and families. They are part of the care team, so they do read the charts, they do enter charting notes, and they're able to actually help patients, they're able to have that communication between providers and patients, you know, being able to be a bit of a conduit for better communication that way. Yeah, there's really like they're just sort of,
They connect with outreach services,
Yeah.
they connect people with social workers, they connect them with housing,
Yeah.
those kinds of things. So, yeah.
Is it more of an active or a passive engagement?
I don't quite know what what that, you know,
Like does the physician at VGH have to call?
yes, a consult
or-
has to be made, yeah, to them. So, you know, you have to go into the surrender chart and identify whether this person has said yes, they would be willing to have Indigenous cultural services, because
Okay.
that's questions being asked at this point. And then if yes, and you see a consult hasn't been made, or if you look through the chart and you know, no notes have been made from the Indigenous team, then you can go ahead and you know, put in a consult. A lot of times these already been put in, but you know, we're always grateful for those opportunities to catch people, you know, at any stage of their care.
What we found is some people won't identify right away either. So it's not a crime to ask them at multiple stages within their journey as well, as they're gaining confidence and knowing that they're actually going to be receiving Indigenous cultural services if they do identify.
Thank you. Any further questions from the audience?
It's Ken. I thought that was a great talk. I'm just wondering if you have these people involved, does that change the overall reflection of the patient on the entire hospital? So is there a difference in perception of the nurses, the physicians, the type of care they receive, or not?
If we're involving the Indigenous wellness liaisons, is that what you're asking?
Yeah.
Okay, so yes, I think what it does is it allows them to feel more confident because they've got somebody who's helping to advocate for them, somebody who's helping to translate what they're not understanding. Already feeling very stressed about being in a facility, sometimes you don't hear all of the things that you're being told and or just are too afraid to ask those questions, which is what we often find. So yes, the Indigenous wellness liaisons have definitely added to a more positive perception of the healthcare system in general. Ken, does that answer your question?
Yeah, and I think Chris Thompson was right. I think if the liaison can feedback in a real time to the physician or the nurses, you know, you could be doing better. We'd love to hear what we could be doing better, because you don't know what you don't know.
Yeah, and you know what? Here's where I will be a little bit you know, implant a little bit of mindfulness around this, that these are your colleagues in these facilities. You know, when you're working with the liaisons, these are part of your direct care team for that patient you're working with. And our liaisons hear and see some pretty terrible things from day to day. You know, they are there usually when there's an end of life, you know, a passing situation, supporting family members and these kinds of things. So also be mindful of the colleagues you're working with from the Indigenous teams at both organizations, because, you know, they really are doing quite some tough stuff. And if they're coming to you, they're coming to you in the hope of better come out of that situation. It's not about a criticism of you or the work. It's that they really are trying to do their job of advocating better for the patients and their families.
Yeah, totally agree.
Yeah.
Thank you, Ken.
Any final question or comment? Well, I guess we'll conclude Grand Rounds there. Thanks again, Sheri and Fancy, for a fantastic talk this morning and the work that you're doing. I'll have Christine send you the link to Miles' talk. And have a good day and good weekend, and we'll see you.
Please feel free to, we've got our email addresses up there as well. Please feel free to reach out at any point in time if you have any questions or want to be connected to any of the services that we're providing as well.
Yeah.
But thank you for having us.
Thank you.
Thanks, guys. Have a great day.